Horns of a Dilemma, the podcast of the Texas National Security Review, TNSR. I'm Doyle Hodges, Executive Editor of TNSR. On this episode of Horns, we listened in on a discussion that was held February 26th at the Clements Center and the Strauss Center at the University of Texas. The discussion featured Dr. Julie Schaefer, who is the Chief Technology Officer for Flu Lab and has held a number of leadership positions in the U.S. government, including Chief of Staff and later Director of Strategy for the Biomedical Advanced Research and Development Authority at the Department of Health and Human Services. Dr. Schaefer's discussion is moderated by Dr. Michelle Malvesti, who herself has extensive experience in the public sector, including leadership positions with the National Counterterrorism Center, the National Security Council, and the Homeland Security Council. Dr. Malvesti and Dr. Schaefer are discussing COVID-19, the novel coronavirus. They look at it from the perspective of the public health response and the impact on national security. Let's listen in.
Truly is a pleasure to be here with Dr. Schaefer today. She's going to help educate all of us on infectious disease outbreaks, on how governments plan for and respond to emerging infectious diseases, and also what can be done to help prevent pandemics in the future. So it's truly a privilege to share the stage with you today. Let's start with some background on the current outbreak so that we all have kind of a foundational understanding about what we know, and perhaps even more important, what we don't know in this sea of uncertainty. So kind of two questions to start off with first. What are coronaviruses in general? And then what do we know about SARS-CoV-2 in particular, including how it's transmitted, incubation periods, severity of illness? So Sure. I'll turn it over to you.
Well, thank you. So it's a pleasure to be here with you all. And I'm also, what's great about something like this is it's not great that there's so much uncertainty, but there is so much uncertainty that this winds up being a dialogue between us and with all the rest of you as well, because there's a lot that we're not sure about yet, and we're all kind of muddling our way through. So let's talk about a little bit what we do know.
Okay.
So we know that coronaviruses are a big family of viruses. Everyone in this room has probably had some coronavirus infections in your life. It's it's how we experience some common colds. This virus is a part of a family of beta coronaviruses that their origin is probably bats. And we think that this is closely related to SARS,
okay,
which emerged in 2003. And
what does SARS stand for? What does that mean?
Severe Acute Respiratory Syndrome. And what we know about these is that they can cause very, very severe respiratory infections for folks, and pneumonia, and making it difficult for people to breathe, and then it can kind of cascading effects in people. We're pretty sure that this emerged in China, and that's really been the epicenter. In Wuhan, in China, has been kind of the epicenter so far, and we think that there are about 80,000 cases. I say we think because we actually don't really know how many cases there have been. We suspect that there are a range of experiences that people have with these infections, from asymptomatic or you don't even know that you're infected, mm-hmm, to these very severe illnesses that can lead to death. So that makes counting really difficult. We know there are reported about 3,000 deaths. We know that there are about 30 countries that are reporting these infections, which we call the disease COVID-19. Well, WHO has named it that, so that's what we'll call calling the disease. And we're going to learn more. I think especially as there's an outbreak in South Korea right now, where they are collecting and sharing quite a lot of data, and that will really help us get a better understanding of things that are still a little bit uncertain to us. For example, how long an incubation period is. So from the point that you are infected to the point that you could show symptoms or transmit to others, that's still a little unclear. We don't know how many people can be able to transmit the infection to others and not know they're sick. We don't know the experience of children with this disease. It seems to not affect children as much as adults, but we have a lot to learn about that. So we know a little. We know to be concerned. And when we know that there's a lot more that we need to know, and we know that we need to make some decisions amidst all of this uncertainty.
Great. Thanks for highlighting that. So you mentioned a little bit on reported cases globally and the fact that we've seen cases in at least 24 countries. What do we know about reported cases here in the United States?
Sure. Well, so we know that a majority of the cases that are of U.S. citizens were among those who were on the cruise ship that was quarantined for a very long time off of Japan, and the United States repatriated those citizens, and they've been in quarantine. Some of them were already ill or were becoming ill as they were coming back, and then some of them have become ill since they've returned to the United States, again going back to this incubation period. So for us, we don't have as much testing in the United States as I think anyone would want. But we don't believe that there is community transmission of COVID-19 in the United States right now. Many of you probably saw reports or may have watched CDC during their press conference talked about the need to prepare that this kind of community transmission is very possible in the United States. We don't know exactly when, but it is something that CDC believes to be a strong possibility.
So many of us, or I would say perhaps most of us here in this auditorium, which we're not public health professionals such as you. We don't have the background that you and some of your colleagues do sitting here. But so for those of us who are not educated on this, some of us may be questioning, why do we not have accurate forecasting on this? How come we are not being able to be accurately told how many people we expect to be infected here in the United States? And when exactly is that going to happen? And where exactly is that going to happen? From your vantage point, could you explain to us the challenges and those type of forecasts and accuracy and, how one goes about conducting that type of forecasting?
Oh, absolutely. And I think it is surprising. I think it kind of can surprise people because we have, in so many areas of our lives, technology has advanced what we know and how fast we know it in so many facets. And so it can catch people by surprise that in an area as important as this, we find ourselves moving slower than I think anyone would want to. I think the first thing that to know about being able to make forecasts is that forecasts are fueled by data. That's the engine and the fuel that's everything for forecasts. We need to know what happened before in order to forecast what will happen in the future. And so this is why we are eager to gain, and certainly epidemiologists and infectious disease modelers are eagerly grabbing as much data as possible to try to understand, first of all, understand more about this virus and what happens when people become infected, but also be able to use these data to get a sense of where it's going, how fast, how big. The other thing that's especially complicating for this is that I'm sure most of you know, here in the Northern Hemisphere, we're in the middle of what we call our flu season. And so our flu season is comprised of influenza viruses circulating, and then also other viruses that produce infections that can feel a little flu-like, which is why there's a concept of influenza-like illness or ILI. That can mask the emergence of new viruses, if the symptoms look like they look like the experience of sickness that you could get from something that happens all the time. So that slows down. And then we also need tests that, first of all, do enough testing that says this isn't something we know about, but then also tests that say, actually, it's this new thing. So it's kind of a two-part. I think that I have dreams, and I hope by the end of this talk, you all will share my dreams about having accurate diagnostics that quickly can tell us what we have and what we don't have. Because right now we a little bit are flying blind when it comes to these influenza-like illnesses.
I hesitate to use the word pandemic, but it's also because I'm not sure I fully understand what the definition of a pandemic is. Could you explain to us, how do we define pandemic? What are the criteria, to meet a pandemic?
Mm-hmm. Well, I think if you are not quite sure of the definition, I think it's because the definition shifts a little bit. Okay. I mean, certainly, those of us who ever spent time in public health school, the definition would be it's a widespread outbreak. So if we a widespread epidemic, so an outbreak is local, something more than expected, and so if we if it's something novel or just bigger than you'd expect, it would be an outbreak or an epidemic, and then when this is happening across geographic area, widespread geographic areas, it's considered a pandemic. I think that it can get a little complicated in the layering because people can make an assumption that a pandemic is talking about severity, which is not necessarily the case. Okay. I think right now the World Health Organization, or WHO, is not calling this experience a pandemic, and their position is that it does not qualify for a pandemic because they see it as a series of epidemics, so that they're not all connected, or I suspect they don't see it enough local transmission or that community transmission happening outside of certain areas. Okay. So it's a little bit of a wiggly term. I think earlier, and I know that we'll be sure to cover this later today, but earlier in pandemic planning, we were very attached to phases of pandemics. And I think as we've experienced different diseases have emerged, and we've had different experiences, a lot of policy makers and planners are moving a little bit away from those phased approaches because they don't see the utility in the names, and because these words can be so loaded.
Okay. As you and I have discussed, in this post-9/11 world, post-9/11 era, we've moved away from defining or discussing pandemics as merely a kind of, quote, health thing, and redefined it to look at pandemics as both threats to health and to national security. Could you walk us through a little bit of that evolution, what prompted that, and how those changing definitions, parameters, and how we choose to view it, not just through a public health lens, but through a national security lens, kind of affects our understanding and resources, et cetera, that we devote to it?
Absolutely. I think that it's commonly understood that there was this beautiful time in infectious diseases when with the wide use of antibiotics and a lot of vaccines, the idea that the infectious diseases were handled. HIV and AIDS kind of took away a little of that conception, and then the terrorist events of September 11th in the United States. The kind of elements that moved toward this concept of pandemics being a national security issue. I think some of the elements are the experiences of the anthrax attacks and the terrorist events of September 11th. The experience of SARS, which was really in 2003, which was very alarming to the public health community and also to the reactions of communities that had these infections, that how scary it was for people, and then in the how people behave when they're very scared,
yes.
and the cascading societal and economic impacts of that fear. In the United States, the experience of Hurricane Katrina was also very foundational in shifting our approach to thinking about these events with the understanding that we have to look at this. This is bigger than health, that we can't look to within the federal government, the Department of Health and Human Services, to do all of the planning and all of the response to these big health events. It's a recognition that it takes the Department of Defense. It takes certainly the Department of Homeland Security.
Yes.
It takes the Department of Education, all having to do this planning together. And all of the events that I listed as being the kind of underpinning are really events that caught policymakers by surprise in some way. They were unexpected. They found the impact of these events unexpected, and so there's a recognition that we need to think about this differently. And certainly all of this came together also with the outbreak of H5N1 avian influenza, which spread to birds, and then also occasionally in people. And when people become infected with H5N1, they become very, very ill. It has a very high case fatality rate, and so that it's a high likelihood if one becomes sick with H5N1 that they could die from it. That scared people and led to a real push towards looking at pandemic influenza differently, because policymakers started thinking, okay, we've had all these experiences. These are things that we weren't quite ready for. Let's start talking about the thing that would affect everybody all at the same time. And most would agree that there are few things that have the capacity to have such a global impact, a negative global impact, as an influenza pandemic. And so that led to the development of the National Strategy for Pandemic Influenza, which really took a holistic, whole-of-government approach, looking at federal, state, and local governments across departments, and say, okay, we need to. This is a multifaceted problem, and we need to look at it differently, and we need to coordinate and collaborate.
So we'll spend some time in a few moments on the preparedness and response and going through exactly this foundation of partnerships that are critical to addressing this from a whole of government, whole of society approach. But to kind of pivot a little back to this word pandemic, we hear pandemic and it just sounds so scary to a lot of people, a lot of us. And yet, not too long ago, another pandemic had emerged in 2009, with H1N1. Describe for us what happened during that event, just kind of, and to the extent that you're able to, given the limited information we have right now with the current outbreak, kind of compare that as to what we experienced in 2009 versus what we are seeing now.
Okay, first of all, does everyone remember the pandemic in 2009? Okay, because it's very interesting, because for those of us who are in the response element of it, I can tell you every single moment. But something that's very interesting about it, and and we're going to talk more about pandemic planning in a little bit. But I would say that it wasn't the pandemic we planned for. We planned for an influenza pandemic to look a lot different than what it was. So. What we experienced in 2009 was an influenza pandemic that emerged in Mexico, in
as
California,
opposed to Asia.
As opposed to Asia, which is a lot of people's assumptions, because a lot of influenza viruses emerge from Asia, and something that was that we can see some parallels to our experience now is it goes back to you don't entirely understand you don't know what you're looking at yet. So with 2009 H1N1, we saw kind of a spike in influenza infections in Mexico. I thought that's very strange. And then we saw some students who traveled, who were in New York, come back from Mexico with a lot of influenza. I thought, that's very strange. Mm-hmm. And then we saw, some severe influenza infections and say, okay, that's really, really strange. And so we at first thought that we were dealing with an emerging influenza virus that was like that 1918 influenza virus that had the capacity to cause very severe illness in people, in a lot of people. And that was and a lot of that was because we didn't know what the rest of what it turns out was there was just a lot of this virus circulating in people. And some people, and just like how it always works with flu, and from what we understand with this coronavirus as well, a lot of people will become ill and recover. And thankfully, a smaller percentage of people will become severely ill. Mm-hmm. And so it just took a while to understand all of that, and that's where it's just the data collection becomes so very important. And we really found out about 2009 H1N1 a little in California, a little bit by a fluke. They were testing a new diagnostic, influenza diagnostic, mm-hmm. and just wanting, collecting the data so that it could be, cleared by the FDA to be used, and they just happened to swab someone who had this novel influenza virus. So it's by chance.
So some of us, for those of us who may not remember H1N1, you referenced, of course, our current flu season, mm-hmm. and some of the complicating factors of that given the current outbreak. But sometimes we don't have the same reaction to our current flu as what we're seeing now with what's been named kind of coronavirus commonly being referred to. Mm-hmm. Whereas, but if you look in the United States alone, and correct me if I'm wrong
Sure.
on this, my understanding is that statistics from CDC, just in the United States alone, in our current flu season, 16,000 deaths in the United States alone for this current flu season. Yeah. And yet are we not having a similar reaction to that versus what we're seeing now being displayed in the press? How can you help kind of explain that, give us insight, and kind of compare and contrast on the similarities and differences there?
Yeah. I mean, I think it's, obviously I will state my bias very clearly that I spent most of my career in influenza. So of course, I think that people should be very interested in influenza and also see it as the threat that it is every single year. I don't know if I have the answer on why. I think there's a familiarity mm-hmm. to that, and there's also because we don't have a lot of precision around everyone who has influenza, so people can call a lot of things the flu, that some of it is the flu and some of it isn't. So I think that helps contribute to a little bit of complacency. I think that the other element that contributes to a sense of complacency with influenza is that there are, unlike this coronavirus, or really any coronavirus, there are vaccines and treatments available for influenza. The vaccine is imperfect, and certainly I spend a lot of my mental energy working toward better solutions for prevention of influenza. The therapies are imperfect, but certainly can really do a lot to both the vaccine and the therapies can do a lot in terms of to save lives. For those who do become, preventing people from becoming severely ill and then treating people who've become severely ill and keeping them from dying. But I think there's first of all, this familiarity. Second of all, that there are some countermeasures available. Contribute to a lack of sense of urgency about influenza. We are using the backbone of a lot of our surveillance systems and a lot about what we know, systems that we've built from influenza, because we see it every year, to help to help plan and eventually respond to this the emergence of this virus.
So I want you to clarify surveillance systems for those of us in the audience who may have a different take on what surveillance system might be. But this is actually a good opportunity for us to pivot. You've helped educate us on the virus, the disease component. So let's shift to what can be done about this. So let's talk about preparedness and let's talk about response. As I mentioned, both from my world on counterterrorism, your world in public health, all of this, homeland security, national security, as we often said in government, is built on this foundation of partnerships. Partnerships that start at a global level. In this case, you mentioned the World Health Organization, going down to individual governments, federal governments, across the world, but then also in the United States, state and local governments as well. Talk to us at each one of these levels, each one of these, key partners. What are the authorities that are available? What are the instruments that are available? What are the intervention options that are available at each one of those levels to help prepare for and respond to these type of public health incidents?
Absolutely, and I will keep it high level so that I don't see any nodding heads out here. At the top level, we have the World Health Organization, and so what they're looking to do is to coordinate across countries. So they have, through a very long process, have developed, and most countries have signed on to these international health regulations. And so what those try to do is help kind of coordinate how countries react when when we have something like an emerging infectious disease. And the goals of those I'll take a moment to highlight because I think they're very important. Is that to encourage sharing of information and transparency, but then also one of the goals, because this is going to come up a lot as we talk about these interventions, is to keep any interventions that countries make in terms of limiting travel and trade to what they call science-based interventions. So to try to thwart or disincentivize countries from making policies that have negative effects for, say, the country that is having an outbreak that's not what they consider science-based. So just that it's policies that are reactionary. Okay. So on a federal level, the federal public health is largely around things that happen between states and things that happen as we're coming and leaving the country. Okay. For those of you who are in public health know well, the real seat of power for public health in the United States are states, because they can tap into their police powers. So because of federalism, anything that happens in a public to respond to infectious diseases really requires an enormous amount of collaboration and coordination at all levels of government, because no one can quite do everything that they'd want to do on their own. So I think that those that follow every single article on this, have already seen there's a little bit of push and pull at the federal, state, and local levels around the quarantining of these few Americans who have been repatriated after they've been exposed to this coronavirus, and communities who are concerned about having quarantined people in their community, seeing it as a threat to their community, and that kind of the push to pull of who has the authority to place them there, who can say no, who can't say no, and then in terms of you can have authority and it may not be the best. Best idea to use that authority. Right.
So could you tell just a little bit more, and I do want you to explain on the surveillance component on that, but just a little bit more on, so essentially in terms of intervention options, there are the pharmaceutical type of approaches. And of course, you mentioned already we do not yet have a vaccine. And would like to hear from you. In general, what does it take to develop a new vaccine? And is this 2 years on the horizon? Is it 6 months, 18 months? Recognizing again that we're operating in this sea of uncertainty, and then perhaps just spend a little more time on those non-pharmaceutical kind of options.
Absolutely.
You mentioned quarantine, isolation, but some of the social distancing, et cetera, so that we have a better understanding of what we might see in our community in the future.
Sure, great. So with vaccines, we aren't where we want to be in terms that there aren't any vaccines that we have. Vaccines that are just entering phase 1 studies, and phase 1 studies are just testing for safety, really. So that they're just, so that means that there are still many steps to go before we know if we have a vaccine that would be safe and effective in people. And then, even so, then there would be additional steps to see how they work in different populations. So while we have many vaccines now, a lot of different entities jumped in to move forward in developing a vaccine. We still have a long way to go. And then the other thing is that even once we develop the perfect vaccine, we still have to make a whole lot of it. We have about 330 million people in the United States, and if this were to become a pandemic in which there's sustained transmission in the communities across America, and a threat to Americans, then we would need enough vaccine available for those that are in the United States. And so that will take some time to make enough vaccine to cover those people. And we would probably need to look at a prioritization of vaccines, and that's where understanding more about the virus is so important, so that you can understand which populations are most at risk. And then depending if there are great disruptions, societal disruptions or disruptions to the infrastructure, then we would also look to prioritize those that kind of keep this society running. So covering healthcare workers and police and the kind of things to keep society functioning would become important. There are treatments, which would be very important, because we do have it looks like we have a smaller percentage of those who become severely ill. It would be great to have treatments available for those people to help them recover. There are a few options that actually were developed for other, they're mostly broad spectrum antivirals, which means that they cover a lot of different, hopefully they cover a lot of different viruses. One in particular was developed with the intention for use in Ebola. It wasn't as successful as they wanted to be for Ebola, but they're looking to be able to use it. It looks like it might have some utility for coronaviruses. Diagnostics, and this goes back to surveillance. We're going to get to your surveillance question. We're going to get there. Make you wait for it. So diagnostics are really important in terms of being able to be able to say what a person has and what they don't have. And so surveillance is built on testing people, usually in healthcare settings. And then those data are reported into public health systems. And so right now most of the testing for this coronavirus is in the United States right now is unfortunately mostly occurring at CDC, which is wonderful facilities and amazing. It's amazing, but they can only do so much. Ideally, you'd want a lot of testing happening at all of the public health labs going around the country, so that we can have more data available that feeds into these surveillance systems, so that we can see where the virus is, so that's where diagnostics are incredibly critical. Having diagnostics that are available in public health labs, then also, and this is something that happened with the Ebola response and especially the Zika response, bringing in private diagnostic companies and having them work on these diagnostics, so we can diversify the number of the types and number of diagnostics available so that we can get more information for better surveillance.
So I keep hearing more information, more information. So
Always more.
Let's pretend you are back in your old job at the White House. Okay. Walk us through, what are the factors that policymakers are weighing right now? What are they thinking about? So, and maybe it is more information. What type of information would that be to help us reduce uncertainty, to help manage the risk, and to help think through decision-making going forward?
Yeah, I mean, I think right now, well, first of all, I'm sure that that many of you saw that the White House has put in for emergency supplemental for funding, pretty modest compared to often emergency supplementals are $6 billion or $7 billion. Interestingly, this emergency supplemental, it looks to repurpose Ebola, about over $500 million of Ebola funds to put towards this, which
so it's reprogramming of other type of money for Ebola.
Which is an important insight in terms of what they're thinking about in terms of the risks that how they're assessing the infectious disease risks.
Okay.
So one could surmise is that their assessment is the outbreak of Ebola that is winding down in Africa is winding down to the extent that they feel comfortable taking money away from that and putting it towards this planning for this response. The big question right now would be trying to get a sense for is containment still possible? So when we think about containment, we're saying, okay, if you have a small enough number of cases, you got to keep it small. We will put a lot of resources into those few cases, into quarantining those who could have been exposed and isolating those who have been exposed and have become ill. I was and doing perhaps intense traveler screening, a lot of intense work at borders to prevent more infections from coming in to the country. So that would be kind of containment. At a certain point, containment no longer becomes feasible. Again, it's very resource intensive, and there's a kind of a process of moving more toward mitigation of, okay, we can't hold the door any longer. Now what we're trying to do is delay in terms of what you want to try to do is keep a big spark from being in one particular area. So kind of push down the total number of infections by a number of interventions, like we can talk about non-pharmaceutical interventions, like social distancing.
What does that mean?
Social distancing is on the simplest point is increasing the distance amongst people.
But how does one do that? What does that mean? Like, what's that mean for like a school?
Yeah. So it's a simple principle that you apply across a number of in a number of spaces. First of all, you wouldn't try to limit mass gatherings. So anytime there's a lot of different people mixing together,
like this,
like this, for example, or like this, we would want to have you'd want to limit that or have more space amongst the people here. It could look like, depending on, what we call dismissal of students from schools. So having students not be in schools for a certain amount of time, huge policy questions about when to do that, for how long.
To be clear, that's an option. No one's suggesting it's...
Oh, yes.
Yes, okay.
Yeah, it is. These are the tools. These are the limited tools that policymakers have to deal with.
And they may or may not choose to use.
Yep, it is. It's like a buffet. Or is often used as like picture. The images use picture slices of Swiss cheese. Each one of them are imperfect and they have holes, but the idea is that you layer on top of them until it becomes opaque. So all of these interventions are imperfect and need to be carefully calibrated to the circumstances. But it is part of the buffet. So social distancing in terms of canceling or postponing mass gatherings. Dismissal of students from schools, telework, very liberal telework policies, encouraging people to work from home. Basically anything that you can think of that would decrease the amount of people gathering together in spaces. So that is a very important, and that's all. Why those interventions, which are broadly called community mitigation interventions, are so important is because they build trust, and that's so important in a response. Is that they require all of us to work together in a collaborative way, but because they tend not to be punitive, they help increase the trust in a community.
It's like a confidence building measure.
It's a confidence building measure. When we don't have the ultimate confidence building measures of widely available, safe and effective vaccines for the particular pathogen that we're facing.
So some of my students who've taken my decision-making course will know that sometimes policymakers, decision makers, we try to turn to the past to help us clarify and understand what we are currently experiencing, especially in novel type situations. And sometimes you learn from successes of the past, but sometimes you also can learn appropriately from failures that have happened. My understanding, there was a decision-making failure in 1976 with the swine flu affair. And I'm curious if you could just explain to us, what were some of those friction points on the decision-making, and what you might apply those lessons learned for the future and what we are experiencing now?
Yeah, sure. So, like a lot of presidents, Gerald Ford was the president at the time, was very influenced by concerns about not ever wanting to repeat the pandemic of 1918, which led to just an enormous amount of lives lost across the world. And so he moved in a very proactive move when there was this emergence of this novel influenza virus to say, we're going to have a mass vaccination campaign for all of the United States. We're not going to take any chances here. And what happened, and there's a wonderful, if you haven't read it, it's a very short book called The Swine Flu Affair by Harvey Feinberg, among others, and it's a great read. But it's a great analysis of what happens if when people don't check back on their assumptions or have inflection points built in, or like, are we still in the circumstance we thought we were in a month ago? Or have the circumstances changed? Should we update our assumptions? Should we update our plans? And so they ultimately did, with some hiccups, did produce a vaccine and started to roll it out. And not only was there not really a pandemic of this particular virus, but also, unfortunately, because the vaccine did cause some very serious adverse effects in some people. So it's considered a very important text to learn from in terms of the right, probably the right intentions, but not building in those the understanding that in any emerging infectious disease, the circumstances are changing very rapidly, and our understanding of the circumstances are changing, and that decision makers need to be nimble and be willing to update their assumptions and understandings as the situation evolves.
So one final question before we open it up to Q&A with our audience members. It appears that we've invested a lot in terms of preparedness and response for infectious diseases. And then I have the sense that perhaps we're not where we ought to be. And I don't know, is this an issue of prioritization? Is it an issue of resources and budgets? Because we do not operate in a resource unconstrained world. Is it an issue that we don't have the right organizational structures or systems or processes in place? What is your sense of where we currently stand and maybe the delta between where we ought to be and need to be, especially to address what we're currently facing?
Absolutely. I think it's a mix of all of those things. I mean, I think there are many papers and books and written about within the federal government how infectious disease threats are managed, who's in charge, is it too spread out across a bunch of different agencies? Do we lose something there? So I'm sure that that's one component. The other component is, I touched upon it for the emergency supplemental. When something new comes, we tend to take resources away from what we consider past and put it toward this new, and then that kind of gets put to the side a little bit
until something spikes.
Until something comes up. So there were resources put into developing a SARS vaccine and SARS therapies, and there were resources and energies put into developing a MERS vaccine or MERS therapies. If we'd had any of those things now, we'd be probably in a much better place than we are. But both of them kind of suffered from other disease threats emerged, and energies were taken off of that and put on that. Right now, a lot of people who work on influenza are not working on influenza. They're working on coronavirus because, as you said, the pie is only so big, and so resources are pulled away from ever kind of finishing the job in one place to put it towards whatever's emerging. For the right reasons, we have to address this thing that's emerging, but unfortunately it comes at a cost of whatever came before it.
Julie, Dr. Schaefer, thank you so much.
Thank you.
Please join me in thanking.
Thank you for listening to this episode of Horns of a Dilemma, and please don't forget to visit our website at tnsr.org.